Thank you very much for inviting me. So I would like to share with you an interesting observation, an intriguing observation we saw when analyzing the data from one of our treatment centers in Liberia. As said previously, despite this being the largest ever Ebola outbreak, we still lack any evidence that any of the therapeutic interventions we are using actually makes any difference in mortality among patients with Ebola virus disease. There has been some screenings of commonly used drugs in vitro that were conducting, looking at the efficacy of these drugs in vitro against Ebola virus. And several drugs actually have shown some effect in vitro. Among those were some antimalarial drugs such as chloroquine or amodiaquine. And antimalarials actually are part of systematic treatment we are providing for Ebola patients in the treatment centers. They are given either presumptively to all the patients admitted to the centers, or they are given based on the positive malaria result. In MSF, we actually prefer the first option, that's we provide as a part of standard treatment, we provide antimalarials to all the patients admitted to the center, with the theory that that might also prevent infections further during the hospitalization time. And the choice, the antimalarial treatment of choice in MSF, but also in most of other treatment centers during this outbreak, is the combination of the ACT combination of artemether and lumefantrine. So I would like to present you some data coming from Foya in Liberia. Foya is a town that is situated right on the Guinean border across the river from Gakedu, where the epidemic first started. So it's part of this triangle where Ebola started at the end of 2013. On the left side for you, you have the treatment center in Foya, which was first organized in a transit unit as a small isolation unit for about 20 patients, and then as a number of cases rapidly increased in August, it kind of mushrooms in a clearly unorganized way in a chaotic, over 100-bed structure in August. So as the number of cases increased very rapidly in August, the team was struggling to manage and take care. So you've seen the structure that suddenly increased from 20 to over 100 beds facility. It was staffed for 20 patients, and then suddenly they had to deal with over 100 Ebola-infected patients. And during that time as well, they experienced shortage of the first-line antimalarial treatment. And during this period, another antimalarial combination drug was used, Artesunate amodiaquine. So in the gray shaded area, you have the period of time when exclusively the combination of artesunate amodiaquine was used instead of combination of artemether lumefantrine. So we use this unfortunate situation of supply problems to explore whether there is a difference in mortality among patients receiving one of the two antimalarial treatments. To do that, we use the routinely collected data in the treatment center using the standardized epidemiological line list that is commonly used in all the centers. In addition, this line list contained also information about the type of treatment prescribed to the patient. So this is coming from the case patient files that were kept in the low-risk zone, so not next to the patient, and only contained information about what type of treatment was prescribed, not necessarily given. So when we look at the patient characteristics, so we are looking at three different groups of patients: patients that were prescribed artemether lumefantrine, patients prescribed artesunate amodiaquine, or those patients that were not prescribed any antimalarial treatment. They were more or less similar in most of their baseline characteristics, but they differed slightly in the CT value at admission, so that the patients in the group of artesunate amodiaquine and those that were not prescribed antimalarial treatment had a slightly lower CT value at admission compared to those in the artemether lumefantrine group. And then the biggest difference is that patients prescribed artesunate amodiaquine, they were admitted at the most busy times of the center, where on average around 100 patients were admitted compared to around 50 patients in the other two groups. The last difference is for the number of cases coming from unique home village, where we try to see whether there is a difference of clustering of patients, if there is clustering within the families, and we see that there is a slightly more clustering in the group of patients prescribed artemether lumefantrine. So in total, we had 381 confirmed cases, of which around 60% died. But then when we look at the mortality by type of treatment, antimalarial treatment prescribed, we see that 64% of patients that were prescribed artemether lumefantrine died, very similar to those that were not prescribed antimalarial treatment. And the mortality in among patients that were prescribed artesunate amodiaquine was quite lower, close to 51%. And then when we look at the survival curve for these patients, so the ones prescribed artesunate amodiaquine are in orange, you see that the survival curves are similar for the first few days of treatment and then diverge after the day 5. When we look at the risk ratio for dying, we see that the patients that were prescribed artesunate amodiaquine had a lower risk of dying compared to patients prescribed Coartem or no treatment, which is 21% lower compared to group prescribed artemether lumefantrine. We did adjusted analysis, so we adjusted for all the risk factors I showed you in the previous table with patient characteristics. And we see that this relative risk of dying decreases further for the group of patients prescribed artesunate amodiaquine. So those patients in adjusted analysis have 31% lower risk of dying compared to the patients who were prescribed artemether lumefantrine. Patients that were not prescribed any antimalarial treatment also had a lower risk of dying compared to artemether lumefantrine group. The difference was lower, so 15% less risk of dying, and it wasn't statistically significant. We could look for other risk factors of dying. So in addition to the type of antimalarial treatment provided in our cohort of patients, those that were older than 60 years were more likely to die. As was shown by Sophie, those that had a high viral load at admission or lower CT value had very importantly stronger risk of dying compared to those with lower viral load at admission. Patients that were prescribed intravenous treatment were also at higher risk of dying, probably because they were more sick at admission. And another factor is the number of patients at admission. So patients that were admitted at the busier times, they were more likely to die as well. We tried to look at do some sub-analysis. So we are looking at antimalarial treatment. So we tried to look separately for the patients that had a rapid malaria test positive. So in those patients, we could see no effect of amodiaquine artesunate on mortality. So risk ratio, it's exactly the same as for the patients prescribed artemether lumefantrine. And in patients that were malaria negative at admission, the effect of artesunate amodiaquine compared to artemether lumefantrine is much stronger. We don't really have an explanation for that, so if anyone has it, you're most welcome to contribute to the debate. Similar to other studies, or other antiviral treatment studies that are ongoing, we observed that the effect of artesunate amodiaquine was stronger in patients that had CT values above 20 at admission, so that were admitted with the lower viral loads. However, the effect is also seen in the group of patients with the higher viral load at admission. So what we show is that in our cohort of patients, the prescription of artesunate amodiaquine was associated with reduced risk of dying compared to prescription of artemether lumefantrine. Whether this is due to the positive effects of artesunate or amodiaquine or harmful effect of artemether lumefantrine, we can't really say from our data. So the alternative hypothesis of artemether lumefantrine being harmful has some biological plausibility as well. So as you've seen in the previous presentation, the patients with severe Ebola disease might have hypokalemia, hypoglycemia. Both these conditions are contraindications for use of artemether lumefantrine. In our center, we had no opportunity to test to do the laboratory testing at that time, that period of time. There are several limitations to this observational study. First, it's an observational study. We are looking at retrospectively collected, routinely collected data in extremely difficult times, very busy times in the center. However, saying that, it's kind of what we are looking at, it's a type of natural experiment. So the exposure itself, type of antimalarial that was prescribed, was not associated with the patient conditions or the clinician preferences. Our exposure is prescription of an antimalarial. So in fact, the data we have, it only tells us what type of treatment was prescribed. We don't know whether this treatment was actually taken by the patient or not. Both treatments, both artemether lumefantrine and artesunate amodiaquine are oral treatments, and they might, severely sick patients might have difficulties taking the treatment. As I mentioned earlier, the quality of data is rather poor. And for example, we have a very intriguing group of patients that were not prescribed any antimalarial treatment. However, we are not really able to explain why they were not prescribed antimalarial treatment. So partially that might be due to the forthcoming shortage of treatment. So the staff might be rationing the treatment available. Maybe at certain times, clinicians might want to wait for the results of the rapid test before prescribing it, but basically we don't really know them. And obviously there might be other confounding factors that we did not measure and that we did not think about them. However, again, saying that, we did extensive sensitivity analysis that all point to the same type of qualitative results. What to do next? We think that these findings are potentially very important. We are encouraging anyone that has any access to other similar type of data to look into it and try to contribute to assuring these results. So as you know, there has been massive malaria mass drug distributions done in both Liberia and Sierra Leone, where millions of doses of ASAC were distributed to the population as a prevention measure. We could explore this. There might be other centers that were using artesunate amodiaquine as a first-line treatment for the Ebola confirmed patients. However, so far we weren't able to find any. And then, on the other hand, there is a need to be sure that indeed artemether coartem, the artemether lumefantrine, is not harmful. So I think that today we have the possibility to monitor much more closely the patients, both from laboratory and cardiac side, to see if there indeed is cardiac effects linked to the use of artemether lumefantrine early in the disease. And then there is a need of confirming this hypothesis of amodiaquine potentially being beneficial. So thanks to WHO, amodiaquine has been put on the priority list for preclinical studies, and there's going to be both in vitro and non-human primate studies done very soon, looking at whether amodiaquine has in animal and in vitro anti-EVD activity. And then, so that's for us to confirm the hypothesis. On the other hand, looking at the data we have, whatever the reason for this differential effect, we believe that the risk-benefit is on the artesunate amodiaquine side, so it would be wise to change the choice of antimalarial for patients that have confirmed Ebola virus disease. So in MSF, we've already done that, but we would encourage others to do the same. Thank you very much.